ocular injuries. So mechanical eye injuries, when you talk about direct force to the eye, we have open globe injuries and closed globe injuries. Open globe injury, obviously the entire wall has been compromised, and that leads to the globe rupture. And this is something where you have increased pressure within the eye, as opposed to a laceration where the full thickness wound caused by direct impact. Essentially, they may have essentially both an entry and an exit wound in those situations. The closed globe injuries, so the wall of the eye is intact. You can have a simple contusion. You may have just a superficial foreign body, or you may have essentially a outer surface laceration that has not compromised the entire wall. So in terms of blunt globe trauma that's closed, you want to take a look at a number of things. So taking a look at the eye, you want to see if the lens is in place or dislocated. Taking a look at the iris, specifically to rule out any kind of hyphema. You want to do fundoscopy, take a look at retinal detachment. You may even, in fact, consider doing, if the patient can tolerate a ultrasound, if you have it on hand. You essentially put a tegaderm over the eye, making sure that the tegaderm doesn't have any wrinkles in it. Put the gel over to assess for retinal detachment field side if that's available. And then retrobulbar hemorrhage. In terms of investigation, you might almost want to consider an X-ray or CT scan based on the trauma involved. If there's an associated facial fracture. And then the management obviously depends on the resultant injury. If there's significant swelling, you're going to need to be transferred to the emergency department to consider for a lateral camphotomy if there's any kind of orbital compartment syndrome going on. But they need urgent emergent ophthalmology consultation. So best to get transferred to the emergency department as soon as possible. For sharp globe trauma, so this is where you have a penetrating injury, or essentially a direct blow that causes increased pressure that causes rupture. These ones you can either have a laceration, blunt, penetrating, and you can also have associated foreign bodies as a result. On examination, you obviously want to take a look to see if there's a foreign body. You want to take a look if there's any kind of gross deformity to the eye itself, decreased visual acuity, and if they have a rapid afferent pupillary defect. In terms of investigations, these people want to do a CT scan without contrast. In terms of management, obviously avoid any kind of pressure to the eye. Leave the foreign body in place, and they need an emergent ophthalmology consult. Retrobulbar hemorrhage. These are essentially rapidly deteriorating injuries. Essentially, there's an accumulation of blood in the retrobulbar space that compresses the veins and then eventually the arteries within the optic nerve, increasing essentially pressure by essentially lifting, straining, or any valsalva maneuvers, including vomiting, are going to make this worse. These need to be treated. Quite a significant risk of loss of vision in about half patients if untreated. These are due to trauma. We'll also take a look for associated ocular injuries such as orbital fracture, globe rupture, and retinal detachments. These patients tend to have increasing pain. The eye will be protruding forward, or there will be proptosis present. There's some subconjunctival hemorrhage. And then they may in fact start to lose vision, which is kind of a later sign, including color. A clinical diagnosis, so that kind of increasing pain and the proptosis should essentially lead you to trying to get that player transferred to the emergency department by paramedics as soon as possible. We in fact need a lateral camphotomy to relieve the pressure, and that typically needs to be done within 2 hours of onset. Can also consider using IV steroids along with that surgical decompression. Globe rupture, so this is a direct blow to globe causing increased pressure leading to a result resulting in a laceration. The ocular contents can leak out, resulting in a deflated appearance, and that leaking out can be seen as a Waddell's sign. So you'll see essentially almost like a waterfall appearance of fluid coming out where the defect is. They'll have chemosis. They may have a teardrop pupil, defect in the pupil as a result, and subconjunctival hemorrhage. They're going to need a CT scan. That helps for taking a look at the amount of swelling, for associated injuries, and whether or not there may in fact be a foreign body still present. Generally speaking, you want to cover the eye up from an on-field perspective, give them antibiotics, make sure their tetanus is up to date, transfer them to the emerge. You want to give them some antiemetics even if they're not feeling sick, as well as some analgesic, because you want to avoid any kind of Valsalva maneuvers that may increase their ocular pressure. And once again, these are urgent ophthalmology referrals from the emergency department. Retinal detachments. So these can occur either at the time of injury or several weeks afterwards. But these are essentially, once again, more blunt injuries to the eye. May in fact be rapid head movement or direct force to the eye. The differential here is that you can have a vitreous hemorrhage or vitreous inflammation, ocular lymphoma, and intraocular foreign bodies. Patients generally have essentially symptoms of floaters, and they may notice essentially a loss of vision associated with it as well. This is, once again, we talked about it before, but if you have availability of ultrasound, it's something where if you have a tegaderm, you can place that flush over the eye, put some gel over, and do an ultrasound to take a look. What you'll generally see on the ultrasound is you'll see essentially the vitreous portion will come up black, and with retinal detachment, you'll see the round globe, but what you'll see instead of the round globe and then essentially a hyperechoic back line of the eye, you'll see some hyperechoity within the vitreous, which normally isn't there. And these people will need an urgent ophthalmological consultation. There's good prognosis for the blunt trauma detachments following surgery. They generally do a laser ablation for these, and then there's guarded prognosis for any kind of penetrating injuries relating to the detachments. Corneal abrasion lacerations. So these are essentially direct scrapes to the eye. They may have associated laceration, so they may have a flap injury. These patients will also need generally speaking, will need an ophthalmological consult. You want to make sure there's no associated foreign body to the eye, or that any kind of secondary infection has developed. Differential diagnosis, so you can have a corneal ulcer, generally speaking, secondary contact, use acute ankle closure glaucoma, hyphema, hypopion, iritis, corneal foreign bodies, conjunctivitis, and what you want to do from an examination perspective, you have present is fluorescein, which will essentially, when you're using blue light, it will fluoresce green. Makes the defect, essentially highlights the defect to make it very easy to see on examination. In terms of management, generally speaking, you want to essentially protect that eye. You may give them some lubrication. You can give them some antibiotics, such as like Viganox eye drops, which is essentially moxifloxacin, and you want to have them see an ophthalmologist for further assessment. These usually, once again, similar to the tongue and an oral mucosa, these heal quite quickly, but can be quite uncomfortable for the first few days. Make sure that they're not wearing contact lenses in the interim. And other advice is that player want to be essentially, when you're doing team coverage, make sure that the players aren't trying to move their own contacts with dirty hands. Conjunctivitis, so this is inflammation of the conjunctiva, the outer surface of the white part of the eye, can be due to allergic inflammation, or it can be due to viral or bacterial. The differential, you can have an iritis that looks similar, uveitis, keratitis, subconjunctival hemorrhage. The examination, you're taking a look to see that injected conjunctiva. There may in fact be some purulent discharge. It's kind of a clinical diagnosis. It's usually self-limiting. More commonly to be viral in adults and bacterial in kids. If in doubt, you can use essentially some topical polysporin eye drops, or consider putting them on, once again, moxifloxacin eye drops. May in fact be a concern if they're not getting better for sexually transmitted infections such as gonorrhea or chlamydia causing the eye infection. And you may want to essentially send a swab if they're not recovering within a few days. Hyphema, this is essentially due to a direct trauma to the front of the eye. You'll see essentially a blood fluid level in the eye at the front, over top of the iris. Essentially what it is layering of red blood cells in the anterior chamber, and you can pick it up on slit lamp examination. You want to prevent any kind of secondary bleeding in this situation, so you want to consider giving them something like tranexamic acid. Give that 1 gram PO 2 to 3 times a day. You want to avoid any kind of anticoagulants or blood thinners, obviously, in these situations, so avoid aspirin or anti-inflammatories for pain relief. Recommending that they sleep 45 degrees up. This maintains that the red blood cells stay in purity and don't obstruct the patient's field of vision over the top of the pupil and lens. Give these patients an eye patch, give them some comfort, and then if they're not resolving, they need to, generally speaking, these patients should see an ophthalmologist anyways, but if they're not resolving, they may need, in fact, certain surgery to extract the blood. Auricular trauma. So here's kind of a special consideration. You get an auricular hematoma, more commonly known as a cauliflower ear, from a chronic perspective. These are due to direct trauma to the ear. You can get an associated periconditis or chondritis, which is essentially inflammation and breakdown of the cartilage underneath the skin in the ear. If you remember from anatomy, the cartilage in the ear is elastic cartilage. And you can also get an auricular abscess as a result as well. On examination, the ear will be tender, tense, will often be fluctuant with a collection of blood. And from an investigation perspective, this is a clinical diagnosis. So you want to have these drained. A couple things from the ear perspective. So you can aspirate these, or you can do essentially an incision and allow it to drain. And then you want to essentially have compression. So you can use dental rolls. You need paper clips, and you can actually even suture. So you can take essentially 2 rolls of gauze on either side and suture them through the ear together, and then remove them after 7 days to allow for essentially continued compression to prevent cauliflower ear. A couple other things from ear perspective that are common from a sports perspective. Treating otitis externa. These are often bacterial, but can also be caused by fungal. You can give them a combination. These people will have essentially inflamed ear canal. They can be quite swollen and sometimes even purulent. If they're very, very swollen, purulent, you want to consider oral antibiotics, but generally speaking, antibiotic drops, plus or minus a combination with a steroid, can be very helpful. In the US, they use something called a Burrow solution. And then otitis media, which is essentially inner ear infection where you'll see fluid behind the tympanic membrane. They may in fact have an infusion as well. Children, they may need essentially ureterostomy tubes. They may need antibiotics, if not self-resolving in these situations. Ruptured tympanic membrane. So this can be caused by a direct blow to the ear. Differential is a otitis media with essentially a fusion. May have an underlying temporal bone fracture, so to consider what the mechanism was and how significant it was. And then in terms of examination, so you'll typically see some blood, or at the very least a defect in the actual tympanic membrane. And a patient may be describing some tinnitus as well. Generally speaking, if it's not healing, you want them to see ear, nose, and throat. Often these will heal by themselves. Want to keep these people dry, so keep them out of water. And you may in fact consider giving them some prophylactic antibiotics if there's any kind of active bleeding, which can essentially predispose them to getting an infection. From an auricular trauma perspective, there's a few considerations that you want to think of. First off, obviously we talked about the auricular hematoma. The second thing is the cartilage that is involved. That needs to be repaired as well. That can break down, so it's important to fix that because it can give a undesirable cosmetic effect otherwise. And then the other thing is with respect to making sure that the tetanus is up to date and considering an antibiotic coverage to prevent any kind of infection setting in, causing a cartilage infection such as a perichondritis or chondritis. When you're setting up to repair these, so if you take, for example, a look at the image on the left here with the laceration involving the cartilage, what you want to do is you can do essentially a pre and post auricular nerve block where you take anywhere between 5 and 10 cc's of 1% xylocaine and do half in a vertical line anterior to the inferior attachment of the lobe, and then the second one a 45-degree posterior to the attachment of the ear. That'll provide essentially full anesthesia of the ear, so to allow you to repair. You want to warn the patient, given the proximity of the facial nerve, they may in fact get essentially facial drooping on that side, including the eye. Also, just let them know that typically lasts for anywhere from 4 to 6 hours. Unlikely to last longer, but it's also a possibility. So letting them know in terms of the risk of not just infection from the local anesthetic and pre and post auricular block, but also the potential nerve injury. That would be extremely rare. The more common one is that essentially they would have a temporary paresthesia through the face on the affected side. Best known case, obviously, is the Mike Tyson and Evander Holyfield fight in 1997, where Mike Tyson bit off a piece of Evander Holyfield's ear.